I'm here to talk to you about what's new in hip fracture, and then I guess it's really an opportunity when you come to visit another country to reflect, well, what are we doing well? Where could we learn? And I always ask people, well, how do you know that you're doing the right thing? And I think as you hear me talk, you can reflect on that. Thank you to Johannes for inviting me to talk. I wouldn't have come and floated down the river. And thank you to Anna for arranging such a great few days. I really feel like in a very short period of time, I've seen a lot. You'll notice the white coats. Australian doctors don't wear white coats anymore, so that was an immediate point of difference, and haven't for many years. So, these are lots of cultural differences between systems for which the evidence base is the same. So what do I do? So the picture on the right, that's the last day that our hospital didn't have any patients in it. Everything ran beautifully that day. There was no one to upset anything. So that was in 2015, and I know that you're opening, people who work here are opening a new ward at a new hospital at the weekend, so, I have shared that experience. Lisa is one of the nurses who works with us, really important to our service and everything I'm about to talk about. And Matt Harper, in the middle of the group below, is an anaesthetist who led the development of our pathway, and we very much work as a team with nursing, allied health, and the orthopedic surgeons. So I might just mention a few things that have given me a lot of knowledge that have contributed to this talk. So the Fragility Fracture Network is an international organisation made up of people from many different disciplines. So orthopedic surgeons, geriatricians, nursing, allied health, absolutely critical to making the organisation. And we focus on the 4 pillars of what we call orthogeriatric care. Acute care, if you don't survive your hip fracture, there's no point having any more pillars. Rehabilitation, if you don't get home, we've kind of fixed the bone and missed the point. Secondary prevention, preventing that person having another fracture is really important. But what we found around the world is that if you don't do that at a national level, you can't really improve care in a system, because each of our systems is really different. The way that we're funded is really different, and you have to understand that in order to work out how to improve care in your own individual system. So those national alliances are really important. I'm going to talk a lot about our hip fracture registry report in Australia and New Zealand. That QR code takes you straight there. I'm more than happy to share the slides though, so don't feel like you have to do that. Think of ANZ HFR a bit like a Fragility Fracture Network in Australia. We have a multidisciplinary group that drive care to improve our hip fracture care. And I'll talk quite a bit about that in the talk that I'm going to give. So it's always good when you start one of these talks to think about, well, is it relevant to me? So is the system that I work in relevant to you? And are the patients that we look after the same, or are they different? So Australia has a population of about 25 million. You in Switzerland have a population of about 8. We have cleaner air than you do. That's mainly because there's a lot of it. We're very big compared to Switzerland. Interestingly, we are similar in our happiness ratings. That's an important rating, I think, reflecting how happy we are in our world. You have more beds than we do. So we have driven a lot of out-of-hospital care because we have less beds. But actually, people live to about the same age. So life expectancy at birth is about the same in Australia and Switzerland. We spend less money on healthcare than you do, and we have less doctors than you do. But we also smoke quite a lot less. And it's one of those things that when you leave Australia, you suddenly remember that other people in the world smoke quite a lot more than we do. Our smoking rates in Western Australia are less than 10%, and you can't actually smoke outside, so it's very unusual. My children have hardly ever seen anybody smoking. Australia also is very, very big compared to Switzerland. So you can see Switzerland over there in the red, very small. We're about the same size as Western Europe. So in Western Australia, this is our state. This is the state that I live and work in. It's the same size as Western Europe. So if you fracture your hip right at the top in Kununurra, you get flown to Perth for an operation. That's actually the same distance as fracturing your hip in Copenhagen and getting flown to Madrid to have it fixed. So those are the distances that we're talking about. Having said that, I understand that you have quite significant rural populations and you fly patients, and it probably takes just about the same amount of time. We've done a lot of work looking at this, and you wait for surgery about the same time, whether you come from Esperance, which is on the Great Australian Bight down here, as if you go to a hospital 45 minutes down the road from ours. So despite you having to get in a plane, it takes about the same time to get to our hospital. Our catchment for tertiary care is the bit outlined in red. So it is quite large. Having said that, 2/3 of the population live in Perth. So most of our population live within the Perth metropolitan area, and we have 3 tertiary hospitals, and we look very like yours. So some years ago, so I think it was 2016, these were published for the first time. And what happened was the body that governs healthcare in Australia decided that they were going to start something called clinical care standards. So what they did was they got a multidisciplinary group of experts together, and we defined what the care should look like in an ideal scenario for our patients. And it follows the way that we care for patients, and I won't spend too long going through this because I've got each one in turn. They've just been revised and were published yesterday, so if you want to go and look at the most current ones, they're on the website. So what does a registry give us? Well, it tells me that 12,153 patients contributed data to our Australian hip fracture registry. 65% of our patients were female, 74% came from home, the average age was 82, a quarter of our patients were over 90. 37% had pre-existing impaired cognition or known dementia, and 45% walked with a stick or a frame. Now, I guess you're all thinking, well, is that the same as your patients? Do you know? Do you collect this sort of information on your patients, and do you know? But I guess that they're pretty similar. We're pretty similar to the UK, we're pretty similar to most Western well-developed countries, and our hip fracture patients pretty much look the same. Once you're looking after about 100 hip fractures, the patients are the same. You're comparing apples and apples. And all our patients are very frail, they're all complex, they all have multiple comorbidities, they increasingly take anticoagulation, mostly with DOACs, whatever you call them, DOACs? Yep, which are increasingly complex. So, we're all looking after the same patients. And that's the benefit of hip fracture. It's really easy to count. There are large volumes of patients who have very similar problems once you know a few demographics about your patient. So the first care standard that we define is care at presentation. And the new definition says a person presenting to hospital with a suspected hip fracture receives care that is guided by timely assessment and management of medical conditions, including cognition, pain, nutritional status, and frailty. Arrangements are made according to a locally endorsed hip fracture pathway. So we expect in Australia and New Zealand that you have defined the care that you expect patients to provide that's relevant to your hospital, that you've agreed what that is. It doesn't vary depending on it's Monday, therefore it's this doctor on call, therefore we do it this way, and on Wednesday we do it a different way. The evidence is such that we should be agreeing that in a locally endorsed pathway. And the indicator that we measure against this is, did you have a cognitive impairment screen at presentation? And then each year we publish things like this related to each statement. So 70% of patients across Australia had a preoperative assessment of cognition. So we're trying to improve that, and we can measure our improvement year on year. We publish this by named hospital on a website. So when we first started presenting registry data on the website, we used to number hospitals so that you only knew your own data, and unless you knew a friend who worked at another hospital and you knew what number they were, you really just were comparing yourself to other hospitals. As the registry's matured, we now name each other. So we're all named. I go through every year and highlight us, so I've highlighted us on that database. And we look at how we perform. So did we actually measure cognition and was it normal? So we're measuring cognition most of the time. The orthopedic registrars do that on admission. They do an AMT4. We train them how to do that. So then, quality statement 2 is about pain management. A person with a hip fracture is assessed for pain at the time of presentation to the emergency department and regularly throughout their admission. Pain management includes appropriate multimodal analgesia and nerve blocks unless contraindicated. And we measure how quickly people get their pain score recorded. We're dreadful at that in our hospital. Our emergency department has a lot of ramping, and we don't do that very well. We also measure how many people had a nerve block, and I understand that you do a lot of nerve catheters here, which is a good thing. Nerve blocks are very good at reducing delirium, pneumonia complications, opiate complications. So across Australia, 92% of patients had a nerve block. We were talking earlier about cultural differences between countries. In the US, only about 3% of people get a nerve block, and that is purely based on culture, not evidence from what I can gather. So countries, despite evidence being the same across the world, we implement different bits of it depending on the history and what people have learned as they went through training, not necessarily to do with the evidence. So the Cochrane review, I did get some slides off Xavier Griffin. I've got a slide later that shows you where to go for the Cochrane review related to hip fracture. But a Cochrane review has clearly concluded that we should be providing all hip fracture patients with a nerve block on admission. We, in Australia, vast majority get a single shot nerve block. That's done by the emergency department staff in most of our hospitals. We've also worked with our country health services. So if you turn up in that country ED a long way from Perth, you will still get a nerve block before you're transferred down to Perth, which is really important for patients when they're getting on and off a plane and being moved around. So orthogeriatric model of care, there's been some significant changes to this in the latest standard, which really have emphasised malnutrition, frailty and cognitive impairment as well as delirium. So that addition of nutrition's been really important, and there's growing evidence around the importance of nutrition in caring for hip fracture patients. So here we actually measure how many people had a clinical frailty assessment and the proportion of patients who were assessed for delirium after surgery. So this is our meeting. So we have quite a unique meeting every morning, a trauma meeting. I normally sit in the corner there where Simon Wall is sitting. So the orthopedic registrar sits at the front, and I'm sure you all have these sorts of meetings. But we also have, I sit there in the front row with the surgeons, the anaesthetists come, and we all meet together every morning and talk about our patients. And at that meeting, we'll identify anyone we might need to go and see together. We might need to make a decision about surgery or not. We might talk about, are they going to be a hemiarthroplasty patient or a total hip replacement patient? We'll go and do a joint assessment together and make that decision. The anaesthetists are really important. Being in the same room at the beginning of the day is really useful because then we know who's on for the day, who's doing that list. We can communicate to each other throughout the day about any problems and go and see patients together if we need to. So we think this really contributes to the way we work together in true collaboration. It really is an important way of building that partnership. And I think it's pretty clear to all of the junior doctors who rotate through that, we are aligned, that you can't crack us, and that we make decisions together between the orthopedic surgeons and the geriatricians. So the clinical frailty scale, this is Ken Rockwood, who invented the clinical frailty scale, is what we use to measure frailty. That's because we had a really keen orthopedic registrar who worked with me, and we looked at clinical frailty scale and compared it to ASA and hip fracture patients and showed that it was a much better differentiator of how patients did and the prediction of how they were going to do. So when an orthopaedic registrar sits in the morning meeting and says to me, there's a 90-year-old person who is clinical frailty scale 5 with an AMT of 4, I immediately have a language that I understand around what they look like, how they're going to do, what's their prediction after surgery, as well as them having 5 medical problems and being on whatever medication. So it really does help us. And I think this was a really good example of the registry being the baseline, which you can add a few, you can do audits on, you can add in extra information, and then you can do really good research on it and get really good information. So we have created videos, myself and orthopaedic registrars, on clinical frailty scale and AMT4s. And delirium assessments. They're 3 minutes long. I'm well aware of orthopaedic surgeons' attention span, so we've really targeted that. And again, you're very welcome to use these. You can find them online. There's also a podcast series in the top right-hand corner. So we have a series called Hipcast. Again, there's lots of different podcast episodes relating to different bits of hip fracture care. So there's interviews with people like Flavia Borges, who did the hip attack study, Mark Newman, who did Regain, but there's also interviews talking with orthopedic leaders about TFNs versus dynamic hip screws and hemiarthroplasties versus total hip replacement. So there really is someone for everyone in that, so feel free to use those. I did add in this, Amy, after you mentioned it. So fasting before surgery, I mentioned nutrition. We know from an audit that we've just done that our patients, despite only needing to fast for 4 hours, often fast for 10 to 12 hours pre-op, because you often don't know when they're going to get called. So this is something that has been implemented in the UK. It's called Sit Till Send. And it is an idea that you just can drink a glass of water until you are sent for, which means that you don't end up going to theatre dehydrated. So really simple, lots of resources available for that. It's something a number of hospitals are picking up. And most patient feedback is hugely, hugely positive. Patients really appreciate being able to drink until they go to theatre. So again, there's a YouTube link there. That's on the ANZ Hip Fracture Registry website, the UK anaesthetist who led this. So Matthew Checkitts did a presentation for us that was recorded and put on the internet, so feel free to use that as well. Nutrition. So this is something that we've changed in the last few years. I met a very impressive dietitian called Jack Bell at FFN meetings, who is absolutely passionate that we should be giving supplements to patients, and there's now evidence to back that up. So it doesn't need a complicated dietitian review. You just need to give supplements to everybody. Very simple, very cheap. You've got Nestle, I think, in the city. I'm sure they'd be really keen for you to give supplements, but really good benefits. If you don't have enough protein, you're not going to build muscles, you're not going to get up and walk. So really good evidence around this now that's growing all the time. You also, importantly, though, have to feed people. So, nursing is so important in nutrition. And sitting out of bed is really important as well. So, doing the basics right, sitting people out of bed, feeding them, adding some nutritional supplements are the things that actually make a really big difference to patients getting better and it being worth the operation that you've done. So in Australia, 88% of patients are seen by a surgeon and an orthopedic surgeon and a geriatrician. So we have quite widespread orthogeriatric care, which isn't necessarily true in every country. So timing of surgery. So this is one of the big changes in our latest standard, because we're reducing the target to 36 hours. You would think that's very long from what I hear from your teams, which is great. There's increasing evidence that early surgery is of benefit. So hip attack, I'm sure most of you have read that. Really good trial because it partly defines the few patients who shouldn't go to theatre early, which is a very, very small group. Hip attack 2 is looking at that group of patients who had a raised troponin because it looks like they have most benefit. So the sickest patients benefit most from early surgery. But this study compared 6 hours to 24 hours Although it didn't show a reduction in mortality, it showed absolutely no harm and in lower risk of delirium and UTI, and understandably reduced pain. It also shortened hospital length of stay, which is really important for most systems. So, the drive to shorter time to surgery is going to grow. I think there's more and more evidence coming that early surgery is really important. And for some systems in the world, that's, really difficult. So going to China, they have hundreds of thousands of hip fractures, most of whom are waiting 7 days to surgery. In the Philippines, you wait 16 days. So, a lot of countries are doing really well compared to others. And trying to define your care is really important. Having a really good partnership with anaesthetists is absolutely critical to getting patients to early surgery, because it is that partnership that's really important. So I've coined the term the single question in preoperative optimization, and essentially it's, can I do anything at all to make them better other than operating on their hip? Because most of the time there isn't. If you've got delirium, it's not going to get better till you've had your hip fracture fixed. It really is a very, very small group of patients who need something doing before they have their hip fracture fixed. It does happen. It's important to recognize those patients, but it is not the majority. So the main reason that we don't get people to surgery is either lack of access to theatres or deemed medically unfit. So there is still a lot more people out there trying to make people better before they fix their hip. So what sort of anaesthetic should you have? I don't think there were any anaesthetists here today, is there? No. Oh, good. Welcome. Really important that you're here. So general versus spinal. So these are some of the Cochrane Review studies. The Cochrane Review didn't show a difference. But it didn't include Regain, which was the New England Journal study published by Mark Newman. And essentially, there really is less difference than we think between spinal and general anaesthetic. It's probably much more important what's in the spinal and what's in the general, in my view. But there is no difference on most outcomes for patients. And if I had a choice in my hospital, I would rather do an extra patient a day with a very good general, than spend extra time doing a spinal for everybody. So, for me, time to surgery, I think in the evidence is more important than what sort of anaesthetic you get. Having said that, trying, to get a consistent anaesthetic mix is quite difficult. So I think that sometimes clouds these studies. So working in partnership with anaesthetists is absolutely critical to reducing delirium and getting good outcomes for patients and reducing post-op hypotension. So we do work really closely together, and I think it is really, really important. But whether you have a spinal or a general is not going to be the thing that defines how good your care is. Surgery. So I took out all of the slides related to surgery because I'm not a surgeon, and I thought that would be really bad. So Xavier Griffin, his group at Barts have done all of the Cochrane reviews on surgical techniques. There's a really lovely website that has all of the studies on it. But actually, I think in hip fracture care, this is the thing that varies the least. I think orthopedic surgeons generally follow pathways and do an excellent job of delivering operations to patients that are the right ones for the right sort of fracture. But it's all on the website, and I would encourage you to go. If you want a really good expert in hip fracture care, Xavier gives very good, engaging talks. However, mobilization is really, really important. So a person with a hip fracture, so this is what our standard says, a person with a hip fracture is mobilized without restrictions on weight bearing, starting the day of or the day after surgery, and at least once a day thereafter, according to their clinical condition and agreed goals of care. And we measure this. So we used to measure whether you were offered physiotherapy. And we realized quite quickly that that really wasn't very useful, because having someone wander past the bed and say, do you want physiotherapy today, is probably not the gold standard. So we now measure whether you actually got up and took a step. And that is a much more useful measure of how effective we've been. So immediate post-operative care, and this is where I think the partnership between surgeons and geriatricians is so critical. So having pathways about early correction of anemia, aiming to get everything out as quickly as possible. So we now do a HemoQ when you come back to the ward. If you're anemic, we'll give you blood straight away, because then we can take the IV cannula out the next day, and that means that you can get up with the physiotherapist. So we try really hard to get everything out day one, catheters out, cannulas out, get people up, and that reduces your complications. As with everything that geriatricians do, we start low and go slow, and we do that with analgesia as well. And we manage bowels and bladder from admission. So, you know, there was a bit of discussion about catheters before. Some of my colleagues in other hospitals are not putting catheters into patients with hip fractures. If you're going to get early surgery, you know, not getting that complication of a UTI is important. We still put catheters in, but we try and take them out day one whenever we can. So, and then the idea is to get everybody up. So older patients are unable to restrict weight bearing. They restrict weight bearing because they've got pain. They don't actually, you know, put weight on if it hurts, and will restrict themselves. So we really work to have everybody designated as weight bearing as tolerating, with a frame, and nutrition is really, really important. So feeding our patients early is really important. We measure that, so we measure the proportion of patients who are designated as unrestricted weight bearing, and the vast majority of patients have that applied to them post-op. I did learn some things yesterday. So in going around different hospitals in different places in the world, you see things that you don't see at home. So I've never seen one of these cushions at home in Perth. So I'm going to take that back and see if we can find those, because I think that might be useful. I am a little bit worried that then people wouldn't get out of bed because they're already sitting up. So we would work quite hard on that. But maybe the day of surgery and maybe the morning after, that might be really useful. I also discovered that this is what's called a SARA study. Apparently you don't have those in Switzerland, but this is something that we've been using a lot. Someone's nodding, so you do have them somewhere. So at the hospitals I went to, they hadn't seen them, and these are brilliant. These are really simple, stop people being hoisted, get people out of bed without putting pressure on nurses' backs, but not needing to be hoisted. So really cheap, really easy to use, and our nurses now love them. And use them a lot. So highly recommend you go and have a look at trialling one of those. So how do we do? So 91% of patients were offered the chance to mobilise. So a physiotherapist went and saw them and said, can we get you out of bed? But only 49% actually stood up and took a step the day after surgery. So that's not good enough. We've then looked at sprint audits to look at why that is. And it's a combination of reasons. It's postural hypotension, it's delirium, it's pain, but less than you'd think. It's mainly hypotension and delirium were the main reasons that people couldn't get up day one post-op. So that tells us that those are the things that we need to work on to get that number higher. And again, in the literature, I think this is becoming really important. There are really good studies coming out saying that this is one of the biggest predictors of how you're going to walk later on in your life. So are you going to return to walking is really predicted by day one mobilisation. So it is really important that we get this right. And then having got people up and got people back home, hopefully, can we minimise the risk of the next fracture? So again, really, really important. We know that osteoporosis is massively undertreated in our populations. And this is where that collaboration between orthopaedic surgeons and geriatricians, pharmacists, endocrinologists is really, really important. So we have some nurse-led pathways, we have some pharmacy-led pathways, and we've worked really hard to try and improve the number of people who get osteoporosis treatment. But it's still woeful. So only 30% of people in Australia who were discharged from an acute hospital had osteoporosis treatment started. So it's a real area of focus in Australia. I like Pathways for Everything, so we've done a project with our orthopaedic service looking at adding the treatment of osteoporosis in patients who don't come into hospital. So these are often people with conservatively managed wrists or humeruses. And we have a pathway that's simple enough for everybody to follow. The idea being that pathway-driven care is okay for the majority. There's a small proportion of this population who needs specialist care and referral to endocrinologists. But osteoporosis treatment should actually be relatively simple. Really important to tailor this for each country and each system. So it depends what medication's available to your population, what the cost of that is, would drive differences in this pathway. But really important to have one and follow it. And you can improve. So, you can increase the number of people who are taking osteoporosis treatment. So I think we're somewhere up the top now, and we were down the bottom before. So we can show over years that by changing something, we can improve the quality of care that we're providing. Ultimately, what patients want. So if you come in with a broken hip, you want to get back home. If you came from home, you want to get back home, and that's a really important outcome. We are getting better and better at following up our patients across the registry at 120 days to see what proportion of our patients get back home. We obviously measure mortality. Mortality is really easy to measure. This is 30-day mortality across all of the hospitals in the registry. We're really easy to spot because we're the biggest one. So we look after the most hip fractures in Australia, which makes it easy to spot us on any mortality funnel plot. This is 12-month mortality. We also record 30-day mortality and look at that. So really important to be able to do that. Of course, it's not all about death. We were talking on the way back from our workshop, weren't we, about, dignity in dying is just as important as living, and this is about quality of life, not quantity, but it is really important to look at particularly perioperative mortality as a reasonable predictor of your quality of care. So, to summarise, what do you need to look after frail older people with hip fractures? So you need effective multidisciplinary partnerships, and partnerships is the word I would use. It's not enough to just all be there. We have to be working in really effective partnerships in order to be delivering the best quality of care. Make sure that you give nerve blocks and expedite surgery. I think that's really important, growing evidence in both of those areas. Developing local pathways for frailty, delirium, and nutrition, really, really important. We've got a pathway that details exactly what we want to do. And if you've got a good EMR, you should be able to put all of this into your EMR and program that care really easily. Allowing weight bearing as tolerated to return to function is really important for that whole multidisciplinary team. And I think this is one of the areas that I probably, we work together, but we challenge each other, and you have to have colleagues who are able to be challenged. I find it really difficult if the orthopedic surgeons that I work with limit weight bearing and we have a robust conversation and they'll explain to me why in that 1% that person can't weight bear, but it really is 1%, and we know that because we collect the data. Treat osteoporosis. You can keep it simple. It doesn't have to be complicated. You can develop simple pathways that increase the number of people who get treated for osteoporosis. And if you want to change in a country, you have to develop a national alliance, and that is how you can make change across a country. But you don't need to start from scratch. There's heaps of resources out there. When we started in Australia, we Australianised the UK data set. There is now a minimum data set that FFN have. It isn't hard. You can start with 1 month of data in a number of hospitals and compare. So that national alliance is really important, and I know that you're considering starting a Fragility Fracture Alliance here. If you're really passionate about hip fracture, the Fragility Fracture Network is in Oslo from the 3rd to the 6th of October. The Fragility Fracture Network is free to join. Feel free to go to the website, register. There's lots of resources on there that are really useful. And then just because I'm from Western Australia, this is Maisie. Maisie's 100. She went home about 10 days after she broke a hip. And these are some of the beautiful places that I am surrounded by in Western Australia. There was actually a crocodile just off the image here. So when I was told that it was really scary going down the air, I'm used to quite a lot worse. So I'm happy to take any questions at all.
Much, Hannah, for this great talk, touching a lot of fields in the orthogeriatrics. I'm sure there are a lot of questions and there's room for discussion now. Please feel free to ask any questions. Go ahead, Martin.
Thank you for your excellent talk. This was very inspiring. I was wondering about the topic of prehabilitation. Of course, this is mainly for scheduled patients,
Yep.
but in your experience, might not be there a group of severely deconditioned patients who are trauma patients who might profit from a bit of delay of the surgery and get fitter in a multimodal way before an operation?
So I think there is a group, but I don't think they're femur fractures. So I think the difference when you've got a femur fracture versus maybe a humeral fracture, although I think the evidence isn't as clear, is that you can't even sit up. So you're going to get complications, and the evidence is growing. Your mortality is affected by your time to surgery. And so I think there is very little. So occasionally you get someone who comes in with new complete heart block, pacemaker, required before surgery. Absolutely, that's important. Who's the anaesthetist? So I've always questioned why we check pacemakers pre-op. And I did actually have the first time ever recently where someone's pacemaker check led to them having something done before they went to theatre because their battery was about to literally stop. But most of the time, even checking your pacemaker is probably not necessary if you've had it checked any time recently or it's not more than 10 years old. Occasionally you get someone who comes in with pneumonia who's actively sepsis. That's a group where you might consider waiting 24 hours. But there are there are a group who you palliate. So we would palliate about 1% of our patients, so very small numbers. But there are a group of patients who it's most appropriate to palliate. That's something that is also very cultural. So different countries palliate at different rates. If you try and talk to people from South America about palliation, it's a really different conversation to speaking to, say, someone from the Netherlands. So, these are things that impact on our rates. But I think it's a really good question. I think that evidence is really unclear for, say, humeral fractures, where the benefits of surgery are maybe less clear, and the possibility of maybe making you a bit better beforehand might be there. But I think the numbers of people the number of studies on humerus fractures, for example, is much lower, the volumes are much lower, the evidence is much less clear. But for hip fracture, it's very clear. There is very, very small number of reasons to not operate quickly. And the hip attack study beautifully defines that. So that would now be my list of things that would stop me operating quickly, because they showed that other than that, it really didn't make any difference.
Okay. Thank you.
I think what you are referring to is the daily business where the one who wants to do the surgery and anesthesia, they are actually discussing whether or not the patient can go. And then a lot of times it's a coagulopathy that is preventing you from doing it. So I was really impressed that your anesthesia, they come to you every morning and discuss the cases that came in. Because usually what happens in our environment is that so the geriatrics will see the patient and do something, and then usually it's prevention of delirium, and afterwards anesthesia whenever they come into play. It's very frequent that coagulation needs to be corrected, and I think those are the delays that bother us the most. And in the meantime, if the patient doesn't have a block, I think that's actually bad for the patient.
It's really bad for the patient. Look, I haven't touched on DOACs. That's a whole nother talk. We're going to talk about in a workshop at FFN some consensus guidelines that we've developed. But I think this is an area where there is unclear evidence, and it wouldn't be clear. It's actually quite a long talk to think about that. I think the evidence is growing that probably early surgery still benefits patients, but that's a group where, for example, if you're well enough to have a total hip replacement, that's a group of patients who are not frail, because they're the only group that should be having total hip replacements, then maybe you could wait a bit longer for that group. But then they're the group that don't tend to have medical problems. So by definition, you're not having a total hip replacement if you've got lots of complex medical problems that aren't under control. So in our hospital, if we're overwhelmed with work, which is quite often, and we have to decide who to operate and who not to operate on a day, we will delay total hip replacements and operate on the really frail person with dementia who's agitated. And they're our top priority for getting operated on quickly. So I think, there is complexity in what sounds like a simple question.
Hello. Great lecture. I really loved it. I'm an anesthesiologist, actually, at the City Hospital in Zurich. And just a few, I have three things. One is I would like to highlight what you said. In Australia, you get a block before you got into the ambulance to be transported to the hospital, which is great. In Switzerland, unfortunately, we're not that far. And I agree, as anesthesiologist, in the beginning I had also fears about the coagulation, but if you have a good surgeon like I have, we can talk to each other and we can do actually also block in complete anticoagulation, and we can do a hip fracture and complete anticoagulation. Now a question, you said the first day is critical for patients to be mobilized.
Yep.
And the problem is hypotension, and they are just not, let's say, a little bit too not awake enough.
Yeah, drowsy.
Now, there's a lot of publications I just watched here. It's a new one from California. They say repeat high dose of dexamethasone may improve recovery, actually, in that term. And in Switzerland, we have a huge hype about rapid recovery because our hip prosthesis should go at home at 3 or 4 days postoperatively. And obviously without doping, our elderly people won't do that. Do you have dexamethasone the first day or any other kind of doping for patients so they will move?
Yeah, so it's a really good question. So look, a standard anaesthetic we have strived for and we found it very difficult. So I think some anaesthetists give dexamethasone as part of their anaesthetic, some don't. And I don't think the evidence is clear. We don't give it day one post-op.
There are 2-3 things about dexamethasone.
Yeah.
It's against vomiting.
Yeah.
So this is 4 milligrams, evidence-based. There is a lot of anesthesia literature. Those finding studies say 4 milligrams enough. The same is for prolonging pain effect of regional anesthesia. Those finding studies with dexamethasone, you have 24 milligrams, you have 24 hours, and if you have 8 milligrams, you have 25 hours. So it's no difference. But in the orthopedic literature, we're talking about 8 milligrams intraoperatively, and then the next day again 8 milligrams or even twice 8 milligrams, according to the rapid recovery for knee and hip surgery studies.
So no, I don't think there's any evidence in hip fractures, but we need the studies. I think there's been a lot of work extrapolating the type of techniques from elective joint replacement to hip fracture that haven't shown benefit. I think that the populations are very different, but I think it often allows us to ask a question about is it important or not, and maybe that'll be the next study that someone does. But I do think we need to do studies and not just extrapolate from arthroplasty surgery, because the patient groups are really different. But having an anaesthetist in our morning meeting has been really, really important. So wherever we can, we try and have the same group of anaesthetists on the same day each week. I know that that's good practice in most surgical units. But coming to the meeting means we all know each other. We actually will have a discussion about the patients. So we do echoes on less than 1% of our patients pre-op. Again, we've worked on a pathway that doesn't need echoes pre-op, which is a barrier in lots of places. And we will often go and see patients together. So I think, those really complicated patients where we're not sure what to do, we'll go and see a patient together straight after the morning meeting, come up with a plan. We will sometimes do something, so it's not that you can't do anything pre-op. You can correct potassium, you can correct anemia. It just doesn't need to take a whole day and delay a person by a day. It might delay a person by 4 hours and mean that by the afternoon they're ready to go. And by having that conversation together, it really has changed the way that we work. And I'd really encourage other people to try it.
And just the last thing, you said intraoperatively, there's no difference between general and regional anesthesia. I 100% agree as an anesthesiologist. But there is a lot of literature now. There will be this year one of Dan Sessler, another meta-analysis showing there's really no difference, including your new publication from the UK. I think we are asking the wrong question.
Yeah.
Intraoperatively, anesthesia will control everything. We're good. We control the brain function, heart function, everything. It will be perfect. The risk is preoperatively, the pain, the polypharmacy, and postoperatively, the hypotension and so on. So it's the wrong question whether we have a spinal or a general anesthesia.
I agree.
The question is about having, as you said, a catheter, a good regional pain management perioperatively. And I think this is something in Switzerland we have a little bit more to talk about.
I think there's a lot of evidence about intraoperative hypotension, so keeping blood pressures high is really important. I think I was talking with Franz yesterday about stopping antihypertensives. That's a really good difference between elective and hip fracture patients. In elective surgery, you will keep antihypertensives going. We absolutely do not in hip fracture patients. We celebrate hypertension on our ward. It happens so infrequently that it's almost a party atmosphere because everybody is hypotensive. And preventing hypotension is really, really important for lots of reasons in our patients.
Any last question, geriatric question? Please feel free to ask in German or French or Italian. We'll be happy to translate.
I do like these themed things. I'm going to try and take a picture of those.
I've got a similar question as he does with doping. So we know that decadurabolin and so on, it works. We know until today with sporty persons. There it might be not illegal, but what would be the indication for elder people? Are there any experiences? Because there we need to have a kickoff when they begin to train. Normally they train, and the people train, but nothing happens. The elder people, they train, but nothing happens with their muscles. So could we sustain them with, let's say, dexamethasone or similar medication? Do you have any ideas, any results of that?
So
experiences?
there's lots of work going in sarcopenias. This is a question about muscle, yeah, right. Yeah, so there's lots of research going on, and I'm not a sarcopenia expert. I think you've had people talk about that who know more than me. I think it's very difficult acutely. It's very difficult to imagine that there is much that will make a difference in a day or two around the time of a hip fracture. But I think there's a lot of evidence about, building muscle, good nutrition, doing the right sort of exercise that has to be much, much more challenging than I think that we think in order to maintain your muscle or grow your muscle as you get older. I'm sure someone else has.
Maybe it's time for a statement from Bern. How do you do it now, and how do you develop? Do you think you will develop something new in the future, or both of you, I guess?
I don't know. We will check. Anna, it's you.
No, definitely. We will initiate a Fragility Fracture Network. We already have the recipe, and I think we're all set.
But maybe there's another orthogeriatric center from Zurich, and I can just tell you that at the university we have difficulties to get local blocks. But do you get it at Michael? Dietrich? Nerve blocks?
The nerve blocks. So we can teach. We've actually got
Habt ihr die
them.
Möglichkeit, präoperativen Nervblock zu machen?
Okay.
Well, I think, no, but I think it's an important question.
Yeah.
We can also raise our arms and say, what
So can I ask-
is available, because in many places it's just not available.
Who does the nerve blocks in Switzerland?
We do it before we even do the X-ray.
Yeah, great.
Okay.
And who does them? The emergency department or?
Yeah.
Yeah, so the emergency department staff. Yeah, great.
Anesthesiologist is doing the block in the emergency room.
So our emergency department staff will do them. And in the country areas, we can train nurses to do them. And we even have a remote ED service that will supervise a local doctor doing them if their patient is flown. So I know you have helicopters that retrieve some of your patients. the staff, they'll make sure they send somebody who's competent in doing a nerve block to retrieve the patient. So we've definitely trained lots of other people to do nerve blocks rather than just anaesthetists, which I think is really important to getting nerve blocks out further into the community.
So in Bern we do catheters because we think that this is longer lasting until the patient is cleared for surgery. If he's unfit, so you have the option to give more medication by the catheter.
Yeah, so I think, there's no evidence that's a bad thing to do. It's a lot easier to do a nerve block, and then we will repeat it in the odd person who doesn't get to theatre in time, because they do last about 24 hours.
And
so, your time surgery, you'd be doing all right with single shot.
And there's another benefit, because you will get the patient cleared from the A&E, because the anesthetist has to come early.
Yes.
So this is the benefit.
That
so
is a benefit,
yeah. Yeah, to get the patient cleared.
Usually 6 hours until surgery, then we do a block. It's more than 6 hours to get a catheter.
Okay.
Okay. How often do you do surgery within 6 hours? Almost never ever with us.
No. I would say we do.
Yeah.
That's ideal. I'd love to be doing that.
20% probably.
Okay.
Yeah, that's fabulous.
Okay, great.
Yeah. Okay. I'll be hanging around, so feel free to come up to me after the break.
Thank you so much again, Hannah. A big applause again.